and he is a assistant professor of pediatrics. He's also a PI at Accords, and his research focuses on drug safety and improving medication safety and surveillance of adverse outcomes, particularly among children with special healthcare needs. And Dr. Andy Kittleson is an assistant professor in the physical therapy program, and he focuses on understanding patient heterogeneity for patients with knee osteoarthritis. And I'm Beth McManus. I'm an associate professor in the Department of Health Systems Management and Policy, in addition to the education core lead at Accords. So we're going to start with.
No.
Oh, Jesus.
I can talk loud too, whatever you want. How's that work? Too low? Good? Okay. All right. Oh, we all named our slides the exact same thing, so let me see if I can find mine. There you go. All right, so I'm Jamie Feinstein. I'm a special needs pediatrician at Children's Hospital Colorado, and I take care of children with special healthcare needs, so kids that have life-limiting disease processes or significant morbidity attached to their diseases for the duration of their entire lives. And I'm also a health services researcher who's used large observational data sets for the last 10 years or so to think about how we improve care for this population, this fragile population of kids. And in the last few years, I've really turned my focus towards drug safety. So Beth asked me today to present a few case examples and kind of applied examples of how we've used large observational data to think about evaluating existing policies out there that are relevant to the kids that I take care of, how we've generated some evidence to inform clinical practice and can disseminate that to some of the stakeholders, as well as generating evidence to shape new policy for relevant stakeholders as well. And then the other goal was just to think about ways that we've chosen creatively to illustrate presentation of our data so that we can take complex data and really get it down to a slide or two when you're presenting to a policymaking group or a stakeholder group. How do you take 2 million observations and turn it into a one slide figure? So I'll do that along the way too. So this is my problem that myself, colleagues face when taking care of these kids. And this is a patient drug list for a child from just a patient that I took care of a couple days ago. And this is a usual patient for me. And you can see that they take, this particular child has 23 active outpatient medications that they're on. This particular child was a 2-year-old. So when I think about taking care of these children, thinking about, is a drug doing its job? Can I pull a drug off? If I'm adding a drug, what am I going to do that disturbs this really complex mixture already? You can see the frustration in this. So kids, like adults, the geriatric population that we typically think of with polypharmacy, these are kids that experience side effects from their drugs. They experience drug-drug interactions, adverse drug events, things like that. The problem that we face is that in the pediatric world, we don't have a lot of evidence that supports our practices and policies around drugs and drug use in children, because this is a fairly small group of kids. They are a relatively protected group of subjects where it's hard to do trials in them. And furthermore, in addition to lacking evidence, we really have very few mechanisms and policies in place to supervise and survey these kids for problems. So that's what I've really focused on. And we've turned to big data, large observational data sets in order to do some of this work, because our population is fairly small to begin with. And because our outcomes of interest, the side effects, the drug interactions, the adverse drug events that we're looking for are fairly rare. So if we're going to be communicating to policymakers, to hospital administrators, people like that, and we want to make valid conclusions and state them with confidence, we've got to have humongous sample sizes in order to look at the questions that we have. So I'll move right into the first example, which is a study that we did to evaluate an existing policy. This is the citation for you. And what we did is we looked at this policy that the Food and Drug Administration had implemented back in 2007. And this is called the Tall Man Lettering Project. It's something where the Food and Drug Administration noted that there are certain drugs that look alike and sound alike when either spoken or written. And they wanted to institute a policy that helped clinicians differentiate between a look-alike, sound-alike drug when prescribing them. Now, this was a policy that was put into place rather quickly and without a lot of supporting evidence to say whether or not this worked. And it was no small task to implement. When you think about what that might affect, it affects all FDA labeling policies. It affects all of the drug compendiums that doctors and clinicians use to look up drugs. It affects how the electronic medical record presents drug data to a clinician or a provider. But does it do anything to reduce error? So I'm going to show you this example using clonidine and clonazepam, which I've listed up here as the drug pair of interest. But you can see what the tall man lettering does is it emphasizes certain parts of the medication name to help clinicians differentiate clonidine from clonazepam, for example, which look and sound alike, but are two drastically different drugs. One is a fairly potent blood pressure medication, and the other is a sedative that we use to control seizures in children and adults. So switching one out for the other has fairly significant problems. And there is a whole list maintained by the Institute for Safe Medication Practices of tens, if not probably 100 drugs that are like this. So we used pediatric data from the FIZ data set, which I think Dr. Tel Bennett talked a little bit about this morning. It's data collected from inpatient hospitalizations for freestanding children's hospitals across the United States. And we looked over a time period from 2004 to 2012 across the policy implementation in 2007. And what we did is we specified 8 potential error patterns that we were going to look for. So an error pattern meaning, going back to that clonazepam and clonidine example, would be day of hospitalization number 1, a child got clonidine. It was discontinued day of hospitalization number 1, and clonazepam was started day number 2 and continued for the remainder of the hospitalization. We developed 8 potential error patterns like that we were going to search for. And then we took the dozen topmost drugs that were concerning from the Institute of Safe Medication Practices that were look-alike, sound-alike drug pairs. And we looked for these patterns for these 12 drugs across those 8 years of data and looked for changes before and after the policy implementation. So it was a massive data set. We had 1.7 million hospitalizations that we looked at. And the long and short of it is that there was no change before and after implementation for those 12 drugs in 2007. And there was never any downward trend anytime during the period of looking at these types of patterns for the look-alike, sound-alike drugs. I can say these things and communicate them very easily, but it's much more effective to give a picture. So thinking about how to present this picture to our stakeholders, which involved the original designers of the Tall Man Lettering Project in the FDA, we wanted to show them what was worth a lot of words in one figure. So this is what we came up with, and what you can see here is we've got 12 panels. The upper left-hand panel is all of the errors together. And the way that each of these graphs is constructed is the x-axis is the study period between 2004 and 12. And then the y-axis is the error rates that were aggregated on a monthly level per 1,000 hospitalizations. The 2 vertical bars outline the 2007 time period. And then if you look to the left, the green lines are the slope before the change in policy. The red lines after the vertical bars are the slope after the implementation of the Tall Man Lettering. And what you can see is that really there's not a whole lot of difference before and after. And perhaps if you look even closely, you may think that the red bars have kind of slightly increased after the implementation of the tall man lettering policy. So this was just a nice, quick way to summarize the data and kind of give people a graphical representation of what was happening. The other thing that was of interest is, drop that, some of these, like guanfacine, which the Institute for Safe Medication Practices said was a highly problematic drug combination. You can see that the number of times that we actually picked up a pattern that was problematic was virtually non-existent compared to some of the other problematic combinations. So, and it calls into attention that maybe some of these lists need to be revised. So I think the big take-home message from this is that for some of these practices that we're putting rapidly into process through quality improvement processes and things like that, we actually need to go back and use some of the data that we have available to evaluate them and make sure that we're maybe causing improvements, but definitely not causing harm. And I'll move into another example of generating evidence to inform clinical practice around drug safety that we've done. So polypharmacy, more medications taken at once increases the potential for drug interactions. This is something that directly affects me as a prescriber, just like I showed you with that list earlier. When I prescribe a new drug onto kind of a background of 20 or 25 medicines, I get hit and hammered with a bunch of alerts. This is an interaction that you need to pay attention to, doc. This is another interaction you need to pay attention to. And it becomes a real big problem for clinicians, for pharmacists, and for the healthcare systems that are being presented these alerts. Enough so that it's become a studied problem called alert fatigue, where we present so many alerts to the clinicians who are making these decisions that they stop paying attention to them. It's kind of the boy who cried wolf problem. So we wanted to think about how can we figure out potentially what are some of the alerts that we can start thinking might be able to be turned down, some of the things that we can maybe turn up, and how can we do this in a way that can draw us from experience nationally and won't be localized to one hospital. We have a working group of hospitals within the FIS system that are actively thinking about how to do this with drug alerts. So this data directly informed this policymaking group. Again, we used FIS data, and this was in 2011. We looked at all hospitalizations during the 2011 year. And this was a pretty data-intensive process. So for each patient hospitalization, we looked at every day of their hospitalization, and we looked at every two-way drug combination that could have happened day 1, day 2, day 3. And these are children on 15, 20 medications. So this is a pretty data-intensive step. We partnered with Truven Health Analytics down in Greenwood Village to do part of this, which they handled the drug interaction checking through their Micromedics formulary and provided us with severity levels, evidence levels to support those severity levels, and then the possible mechanisms of harm. And again, a huge sample size. So we had about 500,000 hospitalizations that we looked at that 1 year, and that was that resulted in 4.5 million drug-drug interactions that children were exposed to when we ran it through the interaction checking database. And when you think about that in terms of what I was just talking about with the alerts, when you're thinking about, for example, major drug interactions which were present, one or more in at least 41% of hospitalizations, that is a lot of alerts being generated for major drug interactions and things that you try to have any hospital system try to turn down major drug interactions, turn down the volume on that, and you will have a legal department probably running right behind you, yelling at you. So, this is a problem, and we were trying to think, how can we figure out of those major and contraindicated drug pairs, if we want to narrow things down so that hospitals can start fine-tuning things, how can we go a further step than this? So we started looking at the actual specific drug interactions, and this list is it's a truncated, this is number 1, 2, and 3 out of several hundred different interactions, and these are the major drug interactions and the prevalences of them that popped up. And for example, the most common one that happened in 13% of hospitalizations was fentanyl and morphine. Now, this is a drug interaction that most medical students, nursing students, providers should know by the first or second year of their training, that when you give a narcotic, you're going to get additive respiratory depression. This is probably one where we're maybe hammering clinicians a little bit too much over the head with it, because we present this every time, and it's something that people really probably don't need to see. The flip side of that is that down at the bottom of this list are fairly rare interactions that most of us don't see over the course of our clinical practice. And those are the ones that we were thinking maybe are the ones that need to be potentially turned up in their volume and presented in a more meaningful way. And it was hard to try to capture whether or not this was true. And this is a little bit of a confusing figure, but the best way that we could figure out how to demonstrate to the group of hospitals that it was these rarer things that made up the bulk of interactions. So this is, the y-axis is the percent of all drug interactions due to one of the classes. So this is the major drug interaction curve, the far most right. And the x-axis here is the percentage of patients that were exposed during their hospitalization to that drug interaction. So it's essentially a cumulative distribution function. So when you drop a line over here from the 50th percent down, so that's 50% of all major drug interactions happened to less than 2.8% of children during their hospitalization. These are rare drug interactions, and the ones that by hammering clinicians with all of these common ones, the fentanyls and morphines, some of the less substantial ones, the moderate and minor drug interactions, we're probably really diluting out where we could be focusing efforts. I am gonna cause trouble with this microphone, I'm sorry. And indeed, since these data have come out, we've started to think about ways, and there are certain hospitals within the system that have started to actually fine-tune and turn those volume knobs and are starting to look at the effects of it now on whether or not clinicians pay more attention to presenting more meaningful interactions. And then the last quick thing that I will go through is evidence that we've been generating to shape new policy. So our special needs clinic here at Children's Hospital is probably the largest special needs outpatient clinic in the United States. We take care of 4,000 plus active patients and their families with really complex medical conditions. And we are involved in a demonstration project where we're definitely a model for other special needs clinics that are developing. So one of the things that we focused on is that Medicare pays for medication therapy management in the adult population, but Medicaid doesn't pay for any analogous medication monitoring in the pediatric population. So we don't have this mechanism to really review these complex children periodically and in a meaningful way. Our special needs clinic, I think, probably hired the first embedded pharmacist about 2 years ago in any of these special needs clinics. And one of the problems that we've been faced with is how do we narrow down from those 4,000 plus patients to the patients that will be most impacted by review with this pharmacist and a meeting with this pharmacist. So for this project, we used Colorado medication claims data, and again, 250,000 kids with 1 year of continuous enrollment. And what we did is we tried to isolate the kids who had the exposures to the highest levels of concurrent medication exposure, so polypharmacy, for the longest durations of time. So for each of the kids, we essentially calculated each day during their year their maximum medication count. We looked at the durations which they spent at each of those medication levels, and then tried to figure out who are those kids, what are the characteristics that identify those kids so that we can start profiling them and pulling them out to be reviewed by the pharmacist. And this is the way that we chose to present the data, which are starting to get fairly complex when you add both a kind of a height of polypharmacy, a duration of polypharmacy, and then trying to figure out who the kids are. So here you can see along the x-axis is the number of concurrent medications. So these are 9 medications being taken simultaneously, 10 medications being taken simultaneously, and then the duration of exposure on the y-axis in months. And you can see real quickly that the red is bad. The percentiles of patients are represented by the colors, and the kids in this upper right-handmost corner are the kids that spend really prolonged levels, really prolonged time at levels of high polypharmacy. So, 10 plus medications being taken every day for 12 months in a row. These are the kind of kids that we need to identify. We actually presented this slide at a policy conference in Washington, D.C. from the Lucille Packard Foundation, who generate a lot of policy around these children and have really started to focus on pharmacy. And then we were able to identify who those people were in that upper right-handmost corner. And these were the kids with complex conditions, with more technology, older kids, and males. So we've actually started to use that data to profile our kids and pull them out and have them reviewed by the pharmacist, which has been working fairly well. So we've been using big data for a number of other things. We have a piece coming out shortly that prescribes the use of big population level data to investigate drug safety and also to think about how we're prioritizing pediatric drug research and funding, which the FDA sponsors the bulk of for pediatrics. So with that, I will finish my portion and turn it back to you guys. I'm happy to answer questions about thinking about ways to present the figures of data or any of the questions you might have had that I glossed over about how the actual studies were done. But with that, I will give it to Beth.